Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Okay, well, good afternoon, everybody. My name is Tim Cras. I'm a scientist and an associate professor at Cincinnati Children's Hospital. And my colleague here is Dr. Adrienne Hammill.
And I'm an associate professor of pediatrics in Cancer and Blood Diseases Institute at Cincinnati Children's and University of Cincinnati College of Medicine. I'm also the research director of our Hemangioma Vascular Malformations Center, where we're able to meet patients and offer clinical trials.
So I need to disclose my research support. So I'm very fortunate to have support from the Lymphatic Malformation Institute, which has funded all of the work that you're going to see today.
And I have several disclosures, including that here at Cincinnati Children's, we're working on several clinical trials, not all for KLA or GLA, with Merck, Venthera, Novartis, and Cerecor. And in the past, we've had drugs supplied for investigator-initiated studies by Pfizer. I'm also have served on advisory panels and as a steering committee member for one of the clinical trials for Novartis and have been a consultant for Novartis. And the other big disclosure is that any medicine that I mentioned today will actually be off-label use because there are no FDA-approved treatments for GLA or KLA, the conditions we'll be discussing today. And last reminder, as we go through this talk, if you have any questions, please put them into the Q&A box, not the chat, and we'll get to those at the end. So to get started, I wanted to remind you that vascular anomalies is a relatively recent and young field in medicine. The first classification came out in 1982, and it was very simple. It divided vascular anomalies into tumors, things that grow, and malformations, things that were present at birth and not expected to grow. Over the past 35 years, this has gotten a lot more complicated, as you can see here. This is the most recent classification from 2018. It's from ISFA, which is the International Society for the Study of Vascular Anomalies. They started releasing this classification in 2014 and have updated it since. But you can see that the basic structure is the same. There are vascular tumors on the left and vascular malformations on the right. And today we will be talking about vascular malformations, particularly on the next slide, lymphatic malformations, and focusing on generalized lymphatic anomaly or GLA and Caposiform Lymphangiomatosis or KLA. KLA was actually first started to be thought about somewhere between 2010 and 2012, but not published until 2014, when it was recognized as a distinct lymphatic anomaly. It was found to be quite aggressive. And initially, on the next slide, we weren't exactly sure how to classify it. In 2014, with that first ISFA classification, GLA was listed as a lymphatic malformation, while KLA, which had been newly published, was provisionally unclassified. There was a lot of discussion about if this represented a new change within an existing lymphatic malformation, or whether it was a separate malformation itself, or whether it might even be more tumor-like because of a second hit, like I mentioned, within a prior lymphatic malformation. But with this most recent update that I showed you, KLA was actually designated as a subtype of GLA. And this is probably because they have such similar phenotypes, although KLA is widely recognized as more severe. But with information that we've learned even since 2018, this subtype designation is almost certainly incorrect, as Dr. Cras will discuss the genetics in a little bit. So generalized lymphatic anomaly was previously known as lymphangiomatosis. It has extensive involvement of multiple different organs, including multiple viscera, can include bones, and often has effusions. The presentation, however, is very different from patient to patient depending on where they have involvement. For example, a patient can present with shortness of breath because of a pleural effusion, with pain from a pathologic fracture if they have bony involvement, or chronic diarrhea and malabsorption if they have gastrointestinal tract involvement. In the next slide, you can see again that this is a multi-system disorder. And both of these photos or radiographs, you can see that there is significant pleural effusion on both sides. In addition, in the left picture, you can see that there are splenic cysts in the the left upper quadrant. So yes, where you are. And on the right slide, you can actually see that there are multiple bony lesions in the vertebrae and also in the pelvis. Effusions can occur, often triggered by infection, trauma, or puberty. And the lesions that we see in GLA are primarily trabecular and spare the cortex, unlike Gorham-Stout disease. In generalized lymphatic anomaly, however, the lungs, aside from pleural effusions, are actually quite normal, as shown here. On the next slide, Caposiform Lymphangiomatosis, the lungs are very different. They are severely affected, even in the absence of effusions. Here you can see there's peripheral intralobular septal thickening, shown with that pink arrow, peribronchial thickening with the orange arrow, and areas of mediastinal infiltration on the right at the sites of the yellow arrows. And you can see that there can also be splenic involvement, that blue arrow, in KLA as well. So KLA is, as I mentioned, an aggressive lymphatic anomaly. It was initially unclassified, and it's still unclear whether this is a completely separate entity or comes from other lymphatic tissue, although the genetic information certainly suggests that this is a completely separate entity. And in the initial Boston report that I showed you before, they demonstrated that there is a high level of mortality with 50% mortality at 5 years from diagnosis. And in fact, only a 34% overall survival. So KLA is pretty aggressive and has a lot of morbidity and mortality. Part of this comes from the chance of hemorrhage from a coagulopathy. And we can diagnose KLA largely based on its distinctive histopathology that we'll look at in a couple of slides. On this slide here, again, in GLA, we often see effusions. The difference is in KLA, these are usually bloody, related to the coagulopathy that I mentioned, and they can, again, involve lung or pericardium. And this consumptive coagulopathy leads to hemorrhage, both into the effusions and in this lower picture, you can see lesions with serpiginous blood-filled lymphatic channels on a mediastinal mass. So you can see the blood there that's leaking into the lymphatics. On the next slide, you can see the histopathology. First, the notable thing are discrete foci of short spindled cells called Caposiform, again, where Dr. Lacroix is showing you. On the next slide, PROX1 staining demonstrates that these are all lymphatic endothelial cells. So again, all of those Caposiform cells in that island in the middle, as well as the distended lymphatic channels in that bottom right corner are all lymphatic. And finally, you can see evidence of hemorrhage because there's hemosiderin deposition and extravasated red blood cells present in these tissues.
So what causes GLA and KLA? So recently there's been new insights that have come from the identification of gene mutations in tissue from patients. And also additional possible insights have come from biomarker analysis that we've done at our institution for proteins in the blood of these patients. So this slide shows you what we know so far about the genetics of GLA and KLA. So firstly, it's important to point out that the mutations, the gene mutations that have been identified are somatic. So this means they're not inherited, passed down from father or mother to son or daughter. So they occur sometime during either the development of the fetus or in early postnatal life. And many of these mutations are activating mutations where they turn on a signaling pathway and hyperactivate it. And this is seen in a lot of tumors and cancers in which many of these gene mutations are also found. So the types of gene mutations that have been identified in GLA, so far they've been primarily mutations in a gene called the PIK3CA gene. So this gene I'll talk about in a few minutes, but you can see in the right-hand diagram here, this diagram shows you the membrane of a cell. We believe this would be endothelial cells in the vascular lesions. And here you can see the receptors, the proteins protruding from the surface of the cell, and then the proteins, growth factors that activate those receptors. When those receptors are activated, that triggers intracellular signaling pathways within the cell that can drive angiogenesis, which is proliferation of these endothelial cells. So there's multiple signaling pathways in these cells that can trigger and drive the angiogenesis pathway, the proliferation of these endothelial cells. Highlighted here in these boxes are the mutations that have been identified in KLA and GLA. So as I mentioned, there's mutations in the PIK3CA gene. Those mutations have also been identified in other vascular anomalies that you see here in the black box. So venous malformations, lymphatic malformations, Close, and Klippel-Trenaunay syndrome. And then the KLA mutation that's been identified in the NRAS gene, Q61R, is shown here. And that's also been identified in tumors and cancers. You can see in the other black boxes here are other vascular anomalies or mutations that have been identified in other proteins in these signaling pathways in other vascular anomalies. So what you can see here is that the genetics is starting to provide us with a roadmap of how these vascular anomalies may be initiated. What's driving them? These somatic mutations in these key signaling pathways that drives proliferation of endothelial cells and normally drives angiogenesis. But in these diseases is leading to hyperactivation of these pathways and excessive angiogenesis. So we believe that these mutations likely occur in endothelial cells, and these are the cells that normally form your blood vessels and also line your blood vessels. So as I mentioned, somatic activating PIK3CA mutations have been found in GLA. So this report in 2019 in JXMed, this group found PIK3CA gene mutations. So the PIK3CA gene, it encodes the catalytic subunit of PI3 kinase, or PI3K. So this is a protein that normally stimulates cell proliferation. But in these patients, they identified 4 distinct somatic PIK3CA variants. So these were found in the tissue from 5 out of 9 patients with GLA. And these same PIK3CA variants also occur in other vascular anomalies. So they occur also in overgrowth syndromes, and they cause hyperactivation of the PI3K-AKT-mTOR pathway. Now, there's an inhibitor of the mTOR pathway called rapamycin. The drug name is Serolimus. So in this study, they showed that rapamycin or Serolimus prevented lipid hyperplasia and dysfunction in a mouse model, which had an active form of this PIK3CA variant expressed in the lymphatics. And they also reported that rapamycin reduced pain in patients with GLA. Now, moving on to the mutations identified in KLA, a somatic NRAS mutation, the Q61R mutation, was identified by Barclay et al. In 2018. So NRAS is a proto-oncogene in the RAS gene family, and it also regulates cell proliferation. So this activating mutation, Q61R in the NRAS gene, was found by DNA sequencing of tissue from the lesions of 10 out of 11 KLA patients. And the frequency of this mutation in the tissue ranged from 1 to 28%, so quite a varied amount. But the NRAS mutation also occurs in tumor cells, and it's known to increase MAP kinase and PI3 kinase signaling, resulting in unchecked cell proliferation in tumor cells. So this particular NRAS mutation is found in greater than 20% of melanomas. It's also found in thyroid cancer and other tumors. So our group's investigating the role of this NRAS mutation in human endothelial cells to better understand how it could be contributing or even causing KLA. I'm going to move on now and talk about biomarkers. What are they and why we would want to use them? So a biomarker is a measurable substance whose presence is indicative of some phenomena, such as a disease or an infection or environmental exposure. Ideally, biomarkers should be easy to measure. For example, measuring a protein in the blood of a patient. This is relatively non-invasive and easy to do. And I'm going to be showing you some data from our work that shows you one of these proteins in KLA and GLA patients. So biomarkers might avoid the need for biopsy of tissue in human diseases. So taking a piece of tissue to try and diagnose a disease is often used and essential for diagnosis. But it can be risky, particularly in vascular anomalies, where that biopsy process can actually trigger bleeding and may even exacerbate the disease itself. So if we have non-invasive biomarkers, that can be very useful. Biomarkers may also predict the prognosis, the outcome of the patient, and could be useful in assessing response to treatments. And then the other thing about biomarkers is that they can lead to identification of factors, proteins, or pathways involved in driving the actual disease process. And then those particular factors could be targeted as a therapy. So our study goal, and the studies I'm going to show you, was to identify biomarkers for different vascular anomalies that might help with patient diagnosis, and also differentiate between different diseases with overlapping features. So diseases that have overlapping features are difficult to diagnose. So if we have biomarkers that differentiate between, say, GLA and KLA, that could be very useful in helping physicians like Dr. Hammill diagnose these patients. They might also reduce the need for a biopsy and could predict prognosis and treatment response as well. So a study that was initiated by Dr. Adams in 2016 was to evaluate Serolimus as a therapy for complicated vascular anomalies. And this study was published in Pediatrics in 2016. So in this study, children and young adults with complicated vascular anomalies were enrolled, and they were given oral Serolimus therapy. Remember, Serolimus is also known as rapamycin and inhibits that mTOR protein. So the primary aim of Dr. Adams' study was to determine the efficacy of Serolimus and its safety. But as a secondary aim, she also included biomarker analysis. And so blood serum was taken both before the patients were treated, and we call this baseline measurements, and also during the treatment protocol itself. So in terms of identifying biomarkers, in this study, we decided to look at some of the known proteins and growth factors that stimulate angiogenesis, which is vascular development, growth of blood vessels. So we looked at vascular endothelial growth factor, or VEGF. We measured angiopoietin-1, angiopoietin-2, and quite a few other growth factors are known to drive the normal process of angiogenesis. We wanted to see if any of these were normally increased and whether they might be contributing to the disease as well. So I'm going to focus in on angiopoietin-2 for the next few slides, because this was the particular factor that we found was abnormally elevated in patients with KLA. And this factor is known that prolonged exposure to high levels of Ang2 can actually drive blood vessel development and actually lymphatic development. So here are the findings of our study, which was very exciting. So this was published in 2017 in the journal Angiogenesis. So the graph here shows angiopoietin-2 levels measured using an analyzer in the serum from the blood of patients before they were treated with Serolimus. So you'll see the black dots here. These are age and sex matched controls, children that didn't have a disease. So this is the levels of angiopoietin-2 in the serum of those controls. And then here we have the square dots here, which are the angiopoietin-2 levels that we measured prior to treatment in patients with GLA. You can see outlined in the red oval here that the KLA patients had very high levels of angiopoietin-2, significantly higher than both GLA and also controls. So this indicates that angiopoietin-2 could potentially be used as a biomarker to differentiate KLA patients from GLA patients, and also to really identify KLA patients. As I mentioned, we measured these biomarkers at baseline before the patients were treated, and then 6 and 12 months on Serolimus. So these are GLA patients, and as I showed you just before, most of the GLA patients did not have elevated levels of angiopoietin-2. There was one patient here, number 46, that did have higher levels here at baseline before treatment, and the levels did decrease in this patient when they were treated with Serolimus. And you can see the chest x-rays on the right side here that shows you that this patient improved, that their effusions improved with treatment with Serolimus. However, the biggest changes that we saw were in the KLA patients. So this graph again shows you the angiopoietin-2 levels on the left axis here, and then the time of treatment with Serolimus, baseline being before the drug was started. The dotted orange lines here show you the maximum levels of angiopoietin-2 found in controls and the mean levels. So again, you can see that these KLA patients, while there was quite a wide spread of levels of angiopoietin-2, they were all highly elevated. But on Serolimus, you can see that the levels dropped considerably. And this also tracked with the response of these patients to the drug. All these patients showed at least a partial response to the Serolimus treatment. So the last thing I want to show you some results from a specific patient. So this is angiopoietin-2 levels in a patient that was treated with combination therapy. And this may be the future in terms of treatment to combine several drugs. So this publication by Dr. Crane from Hopkins and several other groups, including ours, was published in Pediatric Blood and Cancer just last year. So you can see here in gray, there's the levels of normal controls, and you can see some age and sex matched controls here, the angiopoietin-2 levels in the controls. This particular patient who had KLA, as you can see the two black dots here prior to the treatment, this patient had very high levels of angiopoietin-2. In red, you can see how the levels of angiopoietin-2 decreased with the Serolimus treatment initially, but then with the combination treatment with Serolimus and zoledronate, you can see in blue here that the patient's levels of angiopoietin-2 decreased much further until they were down in the levels of controls. And the patient had a phenomenal response to this combination therapy. So by doing these studies and identifying this angiopoietin-2 as a potential biomarker, we realized that it would be helpful to be able to offer this test to physicians and other vascular anomaly centers in this country. And so our clinical lab has now taken this test forward so it can be ordered by physicians at other centers. Samples of serum can be sent in to Cincinnati Children's, and we can do the test here and report the test results to the physician. So you can see the link here. And I just want to finish this section by thanking the Lymphatic Malformation Institute, who funded all of this work. And without their funding, we wouldn't have been able to do this.
Okay, so Dr. LaCroix has already mentioned a couple of the therapies that can be used for GLA or in those cases KLA, but so far most of the treatments haven't been significantly different between the two. In the past, treatment has included symptomatic therapy with pleural or pericardial drainage, surgery including pleurodesis or thoracic duct ligation. For severe cases, even radiotherapy or interventional therapies. And more recently, we've really moved into this era of medication and drug therapies, some of which he already showed you. On the next slide, you can see some of the medical therapies that have been used. In the past, interferon was probably the most commonly used, although since the time of that clinical trial that Dr. LaCroix showed, Serolimus has become the most commonly used. And as he mentioned, zoledronate, one of the bisphosphonates, is probably the second most commonly used for those patients who have bony involvement. For severe disease or flares of disease, steroids and vincristine are often used, as was the case in that patient that he showed. And a number of other medications have been used when necessary to try to stabilize patients and keep them healthy. On the next slide, you can see this is the study that Dr. LaCroix mentioned, again, with Dr. Adams, done both here and at Boston. And in this case, you can see that there were 7 patients with generalized lymphatic anomaly and 7 patients with Caposiform lymphangiomatosis. All 7 of the GLA patients had partial response. They had improvement in disease, in symptoms, in other markers that we used for that, often improvement in effusions. But the KLA patients, while 5 of them showed partial response at 6 months, and by the end, 6 of them did, 1 patient did progress even on the study. And so what we've noticed long-term is that for GLA patients, Serolimus is often sufficient to control symptoms, but for KLA patients, while it is potentially helpful, it's often not sufficient. Serolimus, as Dr. LaCroix mentioned, is an mTOR inhibitor. It's a specific and potent inhibitor of the mTOR complex 1, and it was originally approved as an immunosuppressant to prevent rejection of transplanted kidneys. It was evaluated in that phase 2, as we discussed, for complicated vascular anomalies, but it was never FDA approved for that purpose because that study includes such a wide variety of different diagnoses. They weren't able to recommend it for any single diagnosis and weren't willing to do it for an umbrella group of diagnoses. This is an oral medication available in both liquid and pill forms and generally well tolerated, but it does have some very common side effects. These include mouth sores in a majority of patients, headaches, acne, and other rashes, lab abnormalities, including cholesterol and triglyceride changes in a majority of patients, and the risk of immunosuppression, which in today's day and age with COVID-19 is really a turnoff for a lot of people. Zoledronate, or zoledronic acid, which we've also discussed already, is a bisphosphonate. That class of medicines, bisphosphonates, are commonly used for treatment of osteoporosis to lay down bone that is more difficult for the body to break down. Zoledronate, though, is not actually FDA approved for osteoporosis. Rather, it has been used for cancers to deal with bony metastases and the complications that can come from that, including pain and fractures. And this is where it really makes sense to potentially use it for our patients with GLA and KLA who have bony lesions. Zoledronate is given as an IV infusion at multiple different times. The schedules are very variable at this point. And common side effects include fever and flu-like symptoms that for most people are restricted to the first dose only. And it can also cause low calcium because of the amount of calcium that's going into the bones, and sometimes bone pain. There's actually some theoretical synergism between these two medications when they're used together. As we've already discussed, Serolimus is an mTOR inhibitor. You can see it there, the big yellow circle in this diagram. And zoledronate actually interferes with the effect of RAS on the PI3 kinase pathway by interfering with some of the lipid changes that can happen there. So in theory, these medicines can be even more effective together aside from their individual uses. And this has never been studied prospectively to date. It has become kind of a default standard of practice, although there's not really good information about that. Dr. Taizo Nakano at Colorado Children's is aiming to fix that. He's proposed a prospective study to look at the natural history of these diseases and the response to combination therapy. His trial is called Lullaby. You can see the long name there. And this is going to be performed through Canvas, which is the consortium of investigators in vascular anomalies, a consortium group that we are looking to advance our collaboration to better study these rare diseases in vascular anomalies. As I mentioned, KLA is much more aggressive than GLA and is more prone to flares and bleeding. Because of that, we often have to use rescue medications aside from Serolimus and zoledronate. Ideally, these rescue medicines are just used for a short time, such as a short pulse of steroids or potentially a couple of doses of IV vincristine. But sometimes they are needed on a recurring basis, several days, every month, or things like that. And as I mentioned, the most common rescue therapies or additive therapies in the past or so far have been vincristine and steroids. But now, as Dr. LaCroix mentioned, we can use genetics to better inform our treatment. So where before we were empirically using anything that might work and really reusing things that had worked for other diseases, now we can really focus on the PI3 kinase for GLA and on RAS and that pathway for KLA. So for GLA, on the next slide, again, focusing on diseases, things that would target PIK3CA mutations, the PI3K alpha. One of the medications that's available and in use for some vascular anomalies is Alpellisib. The next slide. Alpellisib is a PI3 kinase alpha inhibitor. Alpha is the predominant catalytic isoform, and it's involved in vasculogenesis and glucose homeostasis and encoded by the PIK3CA gene. It is a potent oral alpha-specific inhibitor, and it inhibits both wild type and mutant PI3K alpha. It was originally developed as a cancer drug and has since been approved for use in breast cancer. It has also been widely used for a number of vascular anomalies with documented PIK3CA mutations, including overgrowth syndromes and even GLA. And there will be a clinical trial opening very soon for the overgrowth syndromes that have PIK3CA mutations. For KLA, we need to look over at RAS, like Dr. LaCroix mentioned. And so targeting the RAS-RAF-MEK pathway, there is a widely used medication called trametinib that is a MEK inhibitor. And that trametinib inhibits both MEK1 and MEK2. Again, it is an oral medication originally developed as a cancer drug for melanoma, which, as Dr. LaCroix told you, has the same exact mutation that we find most frequently in KLA. Also, non-small cell lung cancer and thyroid cancer. It has also been used on a compassionate use basis for patients with KLA who are not responding to other therapies and desperately need good medications, and also for patients with Avms that have RAS and MAP kinase pathway mutations identified. There is an upcoming clinical trial for this as well. It will be looking at its use in complicated extracranial AVMs that have mutations in the RAS/MAP kinase pathway. So future directions in GLA and KLA, I really would call this our wish list, probably for both me and for Dr. LaCroix. First, we really want to be able to diagnose these earlier and easier. In particular, we'd like to be able to tell the difference between them. And as Dr. LaCroix already mentioned, we can potentially do that with our biomarkers. But because genetics has become such an important part, I really look forward to cell-free DNA diagnosis so that we don't require tissue for several reasons. One is that tissue can be hard to reach. Another is that we often go after bony lesions, and bone is actually very poor in telling us genetic results. It just doesn't perform well once you have decalcified the bone. You can't get good genetic information. And finally, as we've already mentioned, there's a high risk of bleeding and potentially even a flare of disease, especially in KLA with the biopsy. The biopsy itself can trigger a disease worsening. And then we'd like to see better treatments. We'd like to see prospective clinical trials for targeted agents in GLA and KLA, particularly looking at those PI3 kinase inhibitors for GLA and other agents in the RAS/RAF/MAP kinase pathway for KLA, including not just trametinib, but sorafenib and some of the RAF inhibitors. And finally, we would like it to become commonplace that we can monitor response to therapy with biomarkers. As Dr. LaCroix showed you, we can do that with angiopoietin-2 in KLA, but that's certainly not the only marker that's out there, and we'd like to have other ways to track GLA as well. And with that, we'd like to finish our talk, and thank you for listening. And then we welcome any questions in the Q&A.
Thank you, everybody. Question is about what part of the body is used for the diagnostic biopsy.
It can be any part that's involved, but it's very important that it be involved tissue right now until we get to these cell-free tests. Right now, it has to be affected tissue. Sometimes there's affected skin. Sometimes you can actually get, again, they're often bony lesions, but those don't work well for genetics. But it's important to get affected tissue right now. And that can be really anywhere.
So the next question is about the proper dose, the correct dose of Serolimus.
That is also pretty variable. In the clinical trials, we would start at a starting dose of 0.8 milligram per meter squared. In practice, then we would follow for levels over time. Those levels on the initial clinical trial were for 10 to 15. Now, that's not what everybody aims for anymore, but there's a lot of variability between practitioners now. I think for aggressive things like KLA, we certainly still think we need a higher level, closer to 10. But for GLA, that's well controlled in a patient who's not in puberty, they may get by with a 5 to 8 and have fewer side effects.
Okay, so the next question is, could you explain how Alpellisib is being used for GLA and talk about any side effects versus benefits?
So Alpellisib is not widely used for GLA at this point. I think there are a couple of patients on it. I know that I have one who started to progress on Serolimus, and that was the reason that we made that change. I guess the benefits, hopefully it improves pain, decreases effusions, over time may be able to improve bony lesions, although bone takes a long time to look better. And the side effects are similar to what have been seen so far in the compassionate use trials. The published series by Dr. Canode out of France, looking at patients with overgrowth where kind of the most common things are rashes, some lab abnormalities. I think the biggest concern we have right now is that it may change metabolism of glucose and create insulin resistance that looks a lot like type 2 diabetes. So far, that seems reversible, but that's something that we're certainly looking at. The other thing we don't know yet is what is the right dose. In that compassionate use trial, they used 250 milligrams for adults, regardless of size, and 50 milligrams for children, regardless of size. The new clinical trial that will be coming up will start with 50 for children and 125 for adults. And so I think we have a lot to learn.
So there's a question about whether extracranial AVMs are genetic.
There certainly are times that extracranial AVMs are associated with other syndromes, but most often they're sporadic. And when we say genetic, so again, kind of what Dr. LaCroix talked about, we know there's a genetic basis to basically all of these things now, but most of them are not inherited. They arise after conception, somewhere in development of the embryo, or sometimes even later.
So it's a great question. Are there precursors to these disorders, perhaps mechanical in nature?
Oh, I don't know. I'll let you talk about that and some of the models, maybe.
Yeah, so the short answer is we don't know, but that's certainly something we're working on. You know, I guess the question is, could there be other triggers that could, you know, either trigger the somatic mutations or could exacerbate the effect of the somatic mutations? We don't know, but those are things we're working on. Dr. Hammill, can you comment on puberty and how that can affect these disorders? Because that is another factor, right?
Yeah, so far we think that that's primarily hormonal, because some of the malformations that have been looked at under the microscope actually have growth hormone receptors or other steroid hormone receptors, and so they can be triggered to grow or to act up around that period of time around puberty. But I don't think we fully understand why or how.
Yeah, and so far, correct me if I'm wrong, there's not a sex bias to GLA and KLA. They equally affect male and female children.
Correct.
Is that correct?
Mm-hmm.
Yeah. Okay. That's a good question, though. It's something we really want to address. So next question is, I wonder if you found biomarkers that would indicate future development of lipedema. From my answer would be not yet. Are you aware of any, Dr. Hammill?
No, I think we know less about lipedema than lymphedema and some of the other vascular anomalies, because it's been partially because it's in a certain age group that is not. It's usually women and usually in their 30s to 40s. So not necessarily the group that we are seeing in our vascular anomalies clinic, which are primarily pediatric. So I think that that's a group that, while it probably has some overlap with PIK3CA, I don't think we have investigated it as well, because it's not in the age group we see most often.
So the next question is, do some of the GLAs with infusions overlap with CCLA?
Certainly, probably. It's difficult to tell, and I think that this is one of the places where genetics will help us a lot. I think the genetics of CCLA have looked more like RASopathy and EPHB4. And so that might help us finally tell the difference, but I think at this point there's a lot of crossover and a lot of variability about how people read, how radiologists read and interpret them. And I think it's important to know, because it seems like, at least in my experience, true CCLA does not respond as well to the medications we use right now. So
there's a great question here. If we want to get involved with research and help out, who do we contact? I imagine most patients have regular blood draws, Also, what if someone has a biopsy? Should we be asking our doctors to send it for research? I would say we would very much welcome, if you're interested in getting involved in our research, you can contact myself or Dr. Hammill, and we have a consent process, and we can enroll you in our IRB studies. So certainly reach out to us at Cincinnati Children's. We'd be happy to help you. Also, there is a patient support group, the LGDA group, and they can also help connect you with us and with other experts in the area. So absolutely, we definitely need patients to help us out so we can advance the research and hopefully develop better therapies in the future and additional biomarkers. So that was a great question. Dr. Hammill, do you have anything to add?
I would just say that in that Lullaby study where we're looking at the combination of Serolimus and Zoledronate, there will be biomarker studies that will go to you and to Michael Dellinger at UT Southwestern to continue working on that and finding other markers for us.
Yes, we really need patients to partner with us to help the research. So thank you for that question. So next question is, what are the best biomarker tests to diagnose lipedema, EDS, and mast cell disease? Not my area. Can you answer that at all, Dr. Hammill?
Again, I think these fall a little bit outside of the group that we're talking about today. Yeah, I can't speak to them very well. Sorry.
So the next one is, in GLA, could the skin, lymphedema, is that the only affected part of the body? Are other systems free of disease or affected as well?
I would say that it is not GLA if only the skin is affected. So that would be just lymphedema, and certainly that can happen. Yeah, GLA would require a much more systemic involvement.
So there's another question about asking what our thoughts are about Serolimus, immunosuppressive drugs, and Bactrim PCP prophylaxis.
So this is a really current area of debate, even among the people who prescribe Bactrim a lot, Serolimus a lot. In the past and on our clinical trial, way back in 2009, we always put patients on Bactrim as PCP prophylaxis. And in fact, there have been cases of PCP or PCJ pneumonia, the pneumonia that became famous due to HIV/AIDS. And so it has occurred, but the cases that have occurred were on patients on high dose Serolimus, so definitely levels like 10 to 15, and usually in very young patients who were also on steroids. So I would think about a patient with KLA who's on vincristine and Serolimus and steroids. It's probably important. Patient on GLA who's being maintained on lower levels of Serolimus, 5 to 8, who's an adult or nearly an adult, may not need that, although I encourage my patients to use it, but I accept that some of them are adults and can opt out, understanding the risks.
So the next question is a very good one, is how common is KLA? And I think the short answer is we really don't know yet.
Right. One of the problems is that until it became an official separate entity in 2014, we had KLAs in GLA. They were the severe cases of GLA, but they were also the multi-system cases of KHE. So a localized tumor that we then found all of these other lymphatic symptoms within them. And so these patients have been historically hidden from us within the other diagnoses. And I think we're just starting to pull them out and diagnose them up front. And so we really don't know how common it is. It's certainly one of our rarest, fortunately, because it's one of our worst.
So certainly we hope with future studies to really answer that question. So a comment from Dr. Steele here. She's seen reports that angiopoietin-2 has been identified as a biomarker in primary lymphedema. So certainly angiopoietin-2 is a biomarker for other diseases, including some tumors. And there are drugs being developed by some of the pharmaceutical companies to target angiopoietin-2. So in the future, we're very interested to know if this could be a therapeutic approach for KLA in the future. And we're doing studies to address that. So the last question here, if angiopoietin biomarker is normal, so it's not GLA, is it another anomaly? I just want to mention that in our study that we published in Angiogenesis, we did also find elevated levels of angiopoietin-2 in patients with KHE, Caposiform Hemangioma, as well as KLA. So there are other diseases certainly for which angiopoietin-2 is increased, including KHE. So it's not just specific for KLA. Dr. Hammill?
You have found some mild elevations in GLA and in some of the capillary lymphatic venous malformations, including Clipotrenane and cloves. And so it's relevant in a number of diseases, although they're not quite so pretty wide margins between normal. But I don't think that elevated angiopoietin or normal angiopoietin rules out GLA, and elevated doesn't. Yeah, sorry, I got mixed around there.
Yeah, I mean, the point I think you're making is it can be used as part of the diagnosis, but is not sufficient. Is that correct?
Right. Yeah, that's well said. Yes, for KLA, it can be really KLA and KHE, very strikingly different from normal, and so clearly begs those diagnoses up front.
Okay, we have a couple more questions, and I think we'll probably have to finish up. Do we know the prevalence of complex lymphatic anomalies? How many of us are there out there?
There are some estimations that we've done recently when we're trying to build a consortia, but I don't have those numbers in front of me right now. It's even combined, it's still a rare disease.
So if not NRAS, if not RAS, doesn't it show up in colon cancer? Would the angiopoietin-2 show up in these type of cancers? So I think the question there is angiopoietin-2 also increased in other diseases with RAS mutations? That's a good question. I'm not sure that's been looked at very carefully. We could look at that in our melanoma cells since we have those. So that's a great question. Do you know, have you seen, that's a very good question.
I mean, we've seen angiopoietin elevated in patients who are really, really sick, and it's unclear if it's just all of their inflammation or if it's an underlying KLA. So.
Certainly, there's a number of different types of tumors in which Ang2 is increased, as I mentioned. Also, it's being explored as a biomarker for ARDS, acute respiratory distress syndrome. And then we've recently got a paper accepted where we found it was elevated in COVID patients who go on to develop renal failure. So that was just accepted in angiogenesis. So it's certainly proving to be we think a useful biomarker for a number of diseases. But certainly we need more biomarkers so we can have a panel of them to help separate different diseases since there's overlap. So I see one more question here. Clipotrenane, does Serolimus have a role in, I guess, treatment of Clipotrenane syndrome?
Absolutely. If patients are symptomatic, it should definitely be discussed. It's important to know what you're using it for, but it definitely has a role in improving day-to-day function and symptoms.
Yeah, so somebody was asking about the name of the article. I'm guessing that's probably referring to our angiopoietin-2 article, and it's in PubMed. If you search our names, you can find that article, and it's published in a journal called Angiogenesis. Okay, well, I think we'll wrap up here, and thank you everybody so much for your questions and for your attention. We really hope this was helpful. And Dr. Hammill, closing comments?
No, I appreciated being able to share this with you and to work with Dr. LaCroix on this presentation, like we try to work in the background on our patients. Hopefully make things better in the future.
Again, thanks to the LE&RN group for allowing us to present today, and for the LMI Foundation for their funding. Okay, thank you very much, everybody.
Thank you.
Bye.